Welcome to NU 623 Adult Healthcare Unit 9 Presentation 3. This unit is going to cover irritable bowel syndrome, celiac, bowel obstruction, and diverticular disease. I ask that you please read the corresponding part of the chapter for additional and required information about these disorders. This presentation is meant to be an adjunct to your textbook. It is not comprehensive, rather a brief outline of the selected material. Additionally, I would like for you to review any course links in your module. Patients with irritable bowel syndrome presents in two ways. Patients can have abdominal pain with constipation or diarrhea, or have painless diarrhea. Left lower quadrant is the most predominant area of pain. Pain quality may be sharp, burning, or dull. Read the subjective presentation on page 579 to understand fully the distinctive symptoms between the two presentations. On exam, patients are usually tender over the left lower quadrant and umbilicus, but can be epigastric with small bowel involvement. Usually, the digital rectal exam is normal, and there is a lack of systemic symptoms such as leukocytosis and fever. Bloody stools will favor irritable bowel syndrome diagnosis. There are numerous differentials to consider here. Review the table in your text for the list. Irritable bowel syndrome is mostly a clinical diagnosis based off of a good H&P. See Table 40.1 on page 580, Advanced Assessment for the Diagnostic Criteria. Labs should be within normal limits in a patient with IBS. A flex sigmoid will typically be normal except for increased mucus. Patients over 40 should get a colonoscopy. A food elimination diet that removes the most obvious offending foods should be carried out with each agent out of a diet for 3 weeks and then slowly reintroduce one at a time. IBS can also present with diarrhea. Some forms of IBS will have alternating constipation and diarrhea. Review the chart on page 531 of your text to help with diagnoses and a comparison of the differentials. Treatment is largely supportive interventions as there is no proven treatment. Help patients identify and remove foods that trigger episodes and encourage stress reduction. All patients should start a dietary fiber supplement, which can help with both diarrhea and constipation. Antidiarrheals should be used for severe diarrhea only, and laxatives should be a short-term alternative. Antispasmodics can help control postprandial pain caused by intestinal spasm. TCAs and SSRIs have been shown to relieve pain. Since this is a chronic disorder, regular follow-up and support is needed. A dietary referral can help patients develop a diet that works for them. Psychotherapy or psychiatric evaluation may be needed for diagnosis and treatment. If patient is refractory to treatment, consult a gastroenterologist. Celiac patients may be asymptomatic or present with a variety of the above symptoms. Exams may be normal, or if there is a severe case, there may be signs of malabsorption or skin disorders. Differentials can include irritable bowel syndrome or forms of irritable bowel disease or food intolerance. Labs for antibodies has high sensitivity and specificity for the disease. Total IgA as well as a small percent will test negative due to an IgA deficiency. An upper GI may show villus atrophy and intraepithelial lymphocytes. Patients who are already on a gluten-free diet will have normal labs and will need a gluten challenge to see if symptomatic. Then check labs. The remaining labs should be considered to check for nutritional deficiencies. There is no cure for this disorder. Encourage patients to remain strictly gluten-free to decrease the chances of developing non-Hodgkin's lymphoma. Aggressive treatment may be done with immunomodulating agents. Regular follow-ups are needed to monitor for complications, malnourishment, and development of other disorders associated with celiac disease. Referrals should be made to a GI for definitive diagnosis and a dietitian to help develop a strict gluten-free diet. Refer to this chart on page 537 to help with differentials presenting with diarrhea. This slide will help you note the difference in presentations for both small and large bowel obstructions. Obstructions at or below the jejunum may present with brown, feculent-type material. Small bowel obstruction pain is usually around the umbilicus or epigastric areas with early vomiting. Perforation produces generalized pain and peritonitis signs. Large bowel perforations should be suspected when there is persistent tachycardia, fever, abdominal pain, and tenderness. CBC may show elevated white blood cells and possible anemia. A CMP may show electrolyte imbalances due to dehydration, fluid shifts, or sepsis. BUN and creatinine will be elevated. Amylase and lipase may be elevated, but this can occur in an intra-abdominal event. Small bowel obstructions will show as an air-filled level in the loops of the small bowel on an abdominal x-ray. X-rays may also show a foreign body or mass. Large bowel obstructions will show gaseous distension of large bowel and kidney bean shape seen in the volvulus. A CT can be done to confirm obstructions and possibly reveal the underlying cause, such as masses. Large and small bowel obstructions can be total or partial, but is a surgical emergency if impending perforation. Conservative treatment can be tried for up to 72 hours, then surgery is indicated if there is a poor response. Patients will require hospitalization with NG tube, IV fluids to correct electrolyte imbalances, and they must remain NPO. Close follow-up will be needed, and referral is made to a surgeon if admitted for conservative treatment or to the ER if emergent. Patients report that abdominal pain is worse after eating and may be relieved with a bowel movement or passing gas in diverticular disease. If a fistula forms, patients may have urinary symptoms. A firm, fixed mass may be palpated at the area of the diverticula. Initial bowel sounds will be hypoactive, but if obstruction develops, could be hyperactive. CBC might show mild to moderate leukocytosis with diverticulitis, but normal in diverticulosis. Hemoglobin and hematocrit might be low if there is rectal bleeding. Increased red blood cells and white blood cells in the UA and positive urine culture suggest a fistula to the bladder. If peritonitis is suspected, get a blood culture. Plain films can reveal free air indicating perforation, ileus, or obstruction. A CT scan is the most accurate to confirm the diagnosis. If the CT can't be performed, an ultrasound can show signs of an abscess, perforation, and obstruction. A colonoscopy should be considered if cancer is suspected or if there is rectal bleeding. See the chart on page 531 to help you with the differential diagnoses for diverticulitis. Uncomplicated or asymptomatic diverticulosis can be managed with a high-fiber diet. Symptomatic mild diverticulitis can be managed with clear liquid diet and rest. If there is evidence of an infection, a broad-spectrum antibiotic is given, such as Augmentin or Cipro, plus metrodiazole for 7 to 10 days. If there is more acute infection, hospitalization is needed with IV antibiotics, hydration, and analgesia. Surgical interventions should be considered if there is no improvement or worsening of symptoms within 72 hours. Close follow-up for resolution and complications in 72 hours, as symptoms are usually relieved, and if not, will require surgical intervention. Patients should be referred to a gastroenterologist as they will need a colonoscopy at some point and if treatment is refractory. A surgeon should also follow in case emergent surgery is needed.